You've tuned to this week's episode of Next Steps Forward, and I'm your host, Chris Meek, and welcome to the new year. As always, it's a pleasure and an honor to have you with us. Our focus is on personal empowerment, a commitment to well-being, and the motivation to achieve more than you ever thought possible. We start 2025 with an outstanding guest. Dr. B. Christopher Frueh is a clinical psychologist by training and professor of psychology at the University of Hawaii Hilo. His development of something called the operator syndrome is helping to change the way we understand and treat the complex set of interrelated health, psychological, and interpersonal difficulties experienced by military special operations personnel. Dr. Chris, as he's known, is also very actively involved in the SEAL Future Foundation, Boulder Crest Foundation, Military Special Operations Family Collaborative, the Mission Within, Vets Inc., the Quick Reaction Foundation, and the military special operations community in general. You're a busy guy, Doctor. Dr. Frueh has testified before Congress and served as a paid contractor for the Department of Defense, Veterans Affairs, U.S. State Department, and the National Board of Medical Examiners. Dr. Bartley Christopher Frueh, welcome to Next Steps Forward.
Right on. Thank you. Thank you, Chris. I'm excited to be here.
And again, we talked pre-show, but I'm a little jealous. I'm here in blustery Connecticut where it's 20 degrees with 40-mile gusts, and you're in sunny Hawaii looking at the ocean. So if I'm a little green with envy here, that's why. So, Chris, what I didn't mention in the introduction is that your dad is a U.S. Air Force veteran who served in Vietnam. Is it fair to say that his experiences and yours growing up as the son of a military veteran who served in combat shaped your decision to pursue the career that you did?
Yeah, definitely. Now, I do want to clarify, my father was a physician. He was not a combatant. But I was about 6 years old when he deployed to Vietnam, and then in subsequent years throughout my teenage, into my teenage years, had quite an awareness of the war, what it meant for the soldiers, even for the people of Vietnam. My father became very involved in the expat community at the University of Missouri of Vietnamese students in the early 70s. So I had a lot of uncles and aunts from that community. But I also want to mention my great-grandfather was a veteran of the Spanish-American War, and he served and fought at the Battle of San Juan Hill in the Michigan militia. And he was one of my childhood heroes. He lived to be almost 100, so I think I was 13 or 14 when he died. So I knew him quite well. And then I went to graduate school with the idea of I wanted to work with veterans.
It's amazing family history there.
Yeah.
No, that's great. And thank you for your family service. So the first chapter of your career from 1991 to 2006 was with the Veterans Administration healthcare system. Would you share your journey to becoming a psychologist and then what you learned during your 15 years serving at the VA?
Sure. Right on. So graduate school at the University of South Florida, my dissertation was with veterans with PTSD. That was the group I wanted to study for my dissertation. And I was able to get a position at the VA in Charleston, South Carolina, for my final year of training, and that's part of the progression for a PhD in clinical psychology. So I went there for 1 year to complete that year of training, and that was the VA and the Medical University of South Carolina. And when that year ended, the gentleman who'd been my supervisor for the first part of the year had left. So I stepped right into that job. And I was there for another 15 years after that. I loved working at the VA. I really enjoyed the patients that I worked with. I really enjoyed my colleagues. I had a really good, solid, amazing team of colleagues while I was there. And I was a full-time clinician for the first 7 years, but had these questions, about our patients, the people we were seeing. And it just so happened we had a file cabinet of data of patient folders going back probably a decade. And it was just, all the psychological data in there. So we started putting that into statistical programs, entering a lot of that data by hand. And we wrote some papers, and that led to kind of the next phase of my career, which was I applied for several federal research grants from the NIH, received those grants. And then the next 8 years that I was there in Charleston were kind of divided between my work in the clinic at the VA and my research programs, which were at the VA and the Community Mental Health Center. I left the VA in 2006, and really I would say the reason I left was I just was very frustrated with VA policies at the central office level, not locally. I was not upset with anything locally. And I, it wasn't that I felt like I had to get out, but some other opportunities came up and I was kind of ready to go and move on.
Obviously, you worked with a cross-section of veterans in the VA, but what drew you to work specifically with military special forces warriors?
So that happened about 10 years ago. It started about 10 years ago, and it was not a plan that I set out to go, okay, I'm going to do these things with this community. It was more organic and kind of random in the way it started. I was at the University of Hawaii, but I also had a position at Baylor College of Medicine in Houston, Texas, where I was the director of research at the Menninger Clinic. They're affiliated with Baylor College of Medicine. And my friends, my circle of guys that I knew and hung out with, most of them came from the special operations community. And pretty early on, it was suggested to me by somebody who was not directly, he was not an operator, but he had served with operators in Afghanistan. And he said, some of these guys are really struggling. Maybe you could talk to them and see what you could help them figure out. And I started with the idea of, well, it's probably PTSD, and I'm going to just put a pin in that because we'll come back to that probably. But I had an assumption that it was PTSD, and my assumption proved to be mostly wrong and certainly massively insufficient to understand the difficulties that these guys, my friends, were experiencing. And essentially, you go, well, in medicine, we talk about what's the primary complaint or what's the starting point. And the primary complaint was this: something's wrong with me and I don't know what it is. And essentially, I've heard that over and over again in the past decade. And starting with the assumption, well, what's wrong with you is probably PTSD, and then come to find out it really wasn't. And yeah, some depression, some anxiety, a lot of anger issues. But underlying that, and it took some trial and error to get there, was massive sleep dysregulation, not just insomnia, but sleep apnea. And that surprised me. 10 years ago, I was not prepared to find that these relatively young, healthy, fit men would have sleep apnea. That didn't compute. The other thing that didn't make sense to me initially was we discovered they all had super low testosterone of an 80-year-old man. And so when a man has low testosterone at that young of an age, he's going to look like he's depressed. He's not going to be sleeping. Concentration is impaired, irritability, anger, mood is going to be low, motivation and energy are going to be very low. Just loss of interest in kind of everything, including working out, including work, including sex. And so a lot changed when we started to address the sleep apnea and the hormonal dysregulation that these guys had. And then that kind of opened the door to look at some other things. And wow, they've all got chronic pain. They've all got, came to realize they all had traumatic brain injuries and I didn't understand this, but from blast exposures. And so now I have to learn about blast exposures. And in 2014, there wasn't much research out there. So that's become something that today I think we now have a much better lock on, but we're still far from really fully understanding this. And it has not, that knowledge, the scientific knowledge of blast exposures has not really leaked out into the broader community of clinicians. And so that's one of the things we face right now for all veterans, I believe.
And how are military personnel different from those of us who aren't serving or haven't served in the military? And then how are special forces personnel different from other military personnel?
Okay. So, right. Good question. Because we're talking about operator syndrome, I want to say a few words about what is an operator and how do we define them and how do I think about this. So first of all, I've worked with mostly a lot of operators, hundreds of operators over the last decade. An operator is somebody who's in one of the special forces units who goes through a special assessment and selection process. For example, Naval Special Warfare, they go through BUD school and they can become a SEAL if they complete it. So SEALs, Green Berets, MARSOC. You've got in the Air Force, you have the pararescuemen and combat controllers. I've worked with operators from Canada and many other countries as well. It's an extraordinarily rigorous selection process. Somewhere between maybe 5 and 8% of everybody who starts the training, it completes it and is selected into those units. And then for the people that make that for a career as an operator, those careers involve several things, but one is an incredibly high intensity level of training on a constant basis. And the level of training between an operator and pretty much any other soldier, for operators, let me use the word dose. The dose of physicality, the dose of blast exposures, the dose of all of what we'll call allostatic load, and come back to that, is magnitudes of order more than it is for most soldiers. But I want to say this very clearly. Operators are not the only ones that have a version of operator syndrome. I've certainly seen it in any soldier doing urban combat. Marines, they may have shorter careers than the typical 20-year career, but the intensity of that combat is profound. Artillerymen, combat engineers, infantry, pilots who are experiencing, the G-forces, fast boat operators, and many of the support folks and intelligence roles that are embedded and work directly with operators. And then the other group that we see these issues in is law enforcement and all first responders. Law enforcement and firefighters have their own versions, some differences, but similarities.
And 25% of first responders are veterans themselves.
That's right.
And my viewers and listeners know I just finished my doctorate earlier this year, and I was focused on first responder and police mental health. And so
all right.
Probably cited a few of your papers in there.
Yeah. So the same stuff that I do with operators we're now applying that in a variety of contexts for first responders. And that's been really rewarding for me.
And the one thing I've highlighted, I'll say the one positive thing of COVID is it has put a big, huge spotlight on mental health, and has significantly reduced the stigma, with the phrase, it's okay to not be okay. Right. And so that's the one positive thing. The negative, one of the many negatives though, is that we're now seeing that tsunami of that mental health crisis across the board come crashing down. And so I appreciate folks like yourself that are sort of in the fight, if you will, for treating those folks. And maybe as a follow-up to that, building trust is always critical for psychologists, no matter who the patient may be. As you look at the differences between special forces personnel, other military personnel, and then the rest of us, what sort of professional challenges does working with special forces create for you and your peers?
Well, good question. A very common story, a very common experience I hear from operators that I work with is that they have not had good experiences with mental health clinicians. Part of the challenge in the military is there's a dual role. So a psychologist, a social worker, or other therapists in the military are both trying to screen and treat soldiers. They're also part of the command structure. So the fitness for duty is a mandate that they have to report on and document. So if you're an operator and I mean, you're going to know if you, depending on what you say to the psychologist, you might get pulled out of your unit. You might miss a deployment. You might get pulled off a training evolution. So there is I would say I'll say this diplomatically, I would say operators are very guarded in what they share with mental health teams in the DoD. On the civilian side, so operators that go to, and this is true of many veterans that go to the VA or go to civilian care providers, one experience, and I hear this all the time with operators, is they have that first meeting with the therapist and they start just tipping their toe into the water and talking about a little bit of the things they've seen and done. And it upsets the therapist. The therapist starts to have an emotional reaction, is crying or emoting. And frequently the the soldier or the veteran just gets up and says, I'm sorry, and I'm sorry I upset you, and they leave. Related to that, I think, is the bigger issue, which is most mental health professionals are not educated. They don't have an awareness of what operators do. They don't know they don't have a sense of the culture, a sense of the experiences. And that's not even their fault per se. When I worked at the VA, I never had a patient who had been a Navy SEAL or a Green Beret. Never. The closest I think I ever came to anything we would consider to be special operations was a couple of force recon veterans who were force recon in Vietnam, and that was so. There's not. I mean, operators are a small percentage of the military to begin with, and many of them just don't use the VA. So it's probably a group of patients that most therapists don't have experience with. Now, I tell you all of that to say this: there is a nonprofit organization now. It's about 2 years old, called the SOF Network.
Yeah.
And so if you're listening and you hear this, the SOF Network, you can look them up on the internet. And what they have is essentially a registry, state by state registry of therapists who have been kind of identified as being culturally competent to work with soldiers, combatants, and especially SOF. They don't have specific cutoffs for who they work with. All of the therapists are individual private practitioners who have joined this foundation. So it's just a way to find them. It's essentially a referring source. They don't pay for the care or provide the care for free. But most of the people in this network are either former SOF themselves, there's a lot of former operators who got degrees and are now therapists. There's a lot of spouses in there of operators, and then there's a number of people who were clinicians in the special operations community when they were active duty and are now out. So there are resources out there. We're starting to find them. They're starting to be developed kind of at the foundation level.
And by SOF Network, you mean Special Operations Forces Network, correct?
Yes.
Just for clarity, just for our listeners, so they know how to look it up.
Yes, thank you. So it's SOF Network.
Thank you. And I want to go back to a comment you made about, a clinician talking to an operator and then just not being able to handle those scenarios that the operators have gone through and are talking about. How do you handle your mental health and your well-being as you're treating these warriors?
Oh, I don't think I have any special challenge with that. I mean, I think it's very common for therapists early in a career to working with veterans to have some of their own emotional reactions. And I certainly did in the first few months that I worked at the VA. I definitely remember. And that was part of what the supervisors worked on with all of us, was acknowledging that, as we're going to have some reactions to hearing the kinds of things that we're not familiar with, that we haven't heard before. But I don't really feel that that went away quickly. And then as I started working with the special operators, yes, there's far more combat over the course of many more years than there is for typical soldiers. A lot of the loss, a lot of the death that operators see and experience in their community actually comes from training as well. So, static line jumps that didn't go well, things like that. I don't really, I get asked this question about vicarious trauma. I don't really feel anything for that.
Do you ever work with the spouses of active duty personnel and private contractors?
I do. Yeah, I have. Yep. And sometimes that's individually from their husbands. Sometimes it's with the husband, with as a couple. And sometimes it's at the family level. I know I've had the pleasure to get to know many adolescent children who are learning and grappling with their parents' experiences.
And I understand that you've also worked with Canadian Special Forces operators. Can you compare and contrast how they're the same as American Special Forces personnel and how they're different, if there are any differences?
The only difference is the accent.
And cheese curd?
And the cheese curd and the tolerance for cold weather.
Fair enough. And more hockey fans than baseball fans, probably.
They're exactly the same. And I've worked with operators in Australia, Israel, Britain, Netherlands, Scandinavia, Poland, probably a few other places. Well, Afghanistan and Iraq as well. I've worked with, done work with some of the interpreters, actually quite a few interpreters who functioned as special operators. So it's, it's the same, the TBI, the hormone disruption, the sleep disruption, the chronic pain, the psychological features, the headaches, the cognitive problems, cognitive impairments. It's universal.
Earlier in the show, you mentioned the phrase operator syndrome. How long did it take you to recognize the concept of the operator syndrome, and how much longer did it take you to fully flesh it out? Was there a particular aha moment?
Yeah, well, I don't know that there was an aha moment. I think there were multiple aha moments early on. And, as I talked with dozens and then eventually hundreds of operators over the years, it became a pattern recognition thing. It's like, I've seen this. I know what questions to ask. Early on, I started keeping just kind of a log of things that I was learning. And as that log got longer, it was a living document. And I started sharing it with operators at some point after probably 3 or 4 years, like, hey, read this. This is just kind of a white paper. This is kind of what I'm understanding. And initially I called it the operator sleep manual. Didn't put mental health in there, but everything it takes to sleep better covers everything that we're talking about here. And that was well received. And I had guys saying, well, you should publish this. And eventually I worked with a team of my colleagues and we did publish it in a medical journal, 2020, a paper called Operator Syndrome. Anybody can find it. Just Google it. It's on the internet. Very easy to find. It's easy to read because it came from this document that was partially written for operators, for their spouses. And so it's a descriptive paper, and you can find the PDF of it. It's public access, so anybody can find it. And we published that in 2020. And then folks kept telling me, you should write a book and say more about this. So that I eventually did that, and we published that this year. That was published earlier this year. No, sorry, we're now in a new year.
I forget too.
It was published in March of 2024.
I think I've written up about 4 checks because I've written 2024 on them already so far. So we're slowly getting into that.
Yeah,
of course,
I didn't do that until about March.
Exactly, and I'm old enough that I still write checks. So that's kind of, I guess, the backstory there. Your research and work with special forces suggests that the injuries our special forces personnel incur while serving our country are extraordinarily complex and require complex solutions. Mm-hmm. Take us through their injuries first, and then we'll talk about the type of treatment they need.
Okay. Well, let's start with a couple of concepts here. So one concept that I want to put out there is allostatic load, and it's cumulative. So allostatic load is a hypothetical concept that's been defined as, and I'll paraphrase this, but it's essentially the stress, the strain, the challenge that gets put on all of the physiological systems in the body. So it's a physiological concept. So when we say physiological systems, we're talking about the nervous system, the neuroendocrine system, the immune, metabolic, musculoskeletal, respiratory, perceptual systems, and of course the cardiovascular system and others. So all of our systems are interconnected, right? Our brain is connected to our gut, is connected to our hormones. So the concept of allostatic load is that the blast exposures, the running, the rucking, the physicality, the sleep deprivation, the chronic high stress and high op tempo, all of this has a profound physiological burden on the human body that in operators is cumulative because there's not a lot of rest. There's not a lot of pauses taken. So over the course of 10 years, 15, 20 or more, this accumulates. Now we know that something, I'll focus here. We know that a concussion, if somebody gets multiple concussions over the course of their life, and the closer those concussions are together, they are more likely to have, some profound injuries and impairments that come from that can be permanent and lasting. So the concept of allostatic load is that operators and first responders and other soldiers just have this massive dose of allostatic load that accumulates over time. So operator syndrome is a framework to take that concept and say, how does this apply? How is the human body affected by the type of activities? So, jumping out of perfectly good airplanes, combat diving, running, rucking, combatives, rappelling, all of that physicality. Then you add on all the massive amounts of blast exposures from demolitions, breaching, shoulder-fired rockets, even, sniper rifles, and even handguns involve a micro explosion. And that causes an invisible form of damage we're only really kind of tuning into probably the last 10 years or so. So what I'm talking about here, what makes this complex, is that, I'll get to the injuries in just a moment, but they're all interrelated. And that's partly why we want to talk about this as a syndrome, is it's not just a traumatic brain injury. It's a traumatic brain injury that connects to your sleep and affects your sleep. And together, those affect your hormones, and all combined, all of these things have effects on each other, which can lead to a vicious cycle. One problem causes cascade of problems everywhere else. But to turn that around, this is the message of hope here, is there is good hope for recovery. You treat one issue, and that can have a positive ripple effect on the other physiological systems. And if you start doing multiple treatments for multiple systems, then you're really going to see some really great benefits. So the recovery and healing is very possible. But let's talk about what the syndrome itself is. So operator syndrome really starts with traumatic brain injury. And I'll just go down the list. Sleep disturbance with sleep apnea, hormonal dysregulation, primarily low testosterone in men, but that's not the only domain that gets affected. The perceptual systems have impairments, so hearing, vision, balance, chronic pain, headaches. A lot of guys have chronic migraines. The cognitive impairments to concentration, to short-term memory, even just staying organized. And of course, learning new material is much harder after you've had a traumatic brain injury. And then we have the psychological, which I would say kind of in no particular order, but the anxiety, depression, and anger kind of are at the forefront. Some of the PTSD symptoms, and also high potential for addiction. So heavy drinking is very common, and as well as using some of the other drugs that are out there. And then all of that, I apologize for talking for so long without taking a breath, but then all of that cascades into the social systems. So we start with the physiological systems, but then our social systems, marriage, parenting, fitting into a civilian society, the intimacy challenges, emotion. I mean, yes, sexual intimacy is a problem for many operators after a certain point, but the emotional intimacy is a struggle too. A lot of guys will talk about losing their empathy. Also toxic exposures, the radiological, the biological, all the bad water, the not so clean air and whatnot that are in many austere environments. Those are having effects, respiratory illnesses, cancers, other things. And then the last is the existential concerns, which we could spend a whole hour talking about right there. But this would include things like the horror of killing, the thrill of killing. A very common statement, a common perspective I hear is that soldiers actually who do enough of it, who do a lot of it, come to enjoy it, come to find it thrilling, and then miss it later. And then also feel very guilty about those perspectives of having enjoyed it and missing it. And of course, we also have all the loss and the grief, sometimes guilt, survivor's guilt. We might call it moral injury or shame sometimes. At the end of a career, we often are faced with things like that sense of that loss of identity, loss of purpose. Who am I now? Loss of tribe. I'm no longer with the people I served with. And that's a challenge. And then last, a lot of guys will talk about feeling betrayed by their nation, by society. Many will talk about, soldiers will talk about loss of faith in humanity or God. So there are these profound existential issues that I don't really think of as being psychiatric illnesses. I think of them as just, humans struggling with being humans and the things that they've experienced and seen and done.
Can you go into a little bit more detail? I haven't heard anything or much, I guess, about veterans feeling betrayed. Can you just give a little more color on that, please?
Well, yeah. So 2 points, several points. It's not two. It's probably several. One is in special operations, very few people, very few operators go out on a high note at the end of their career. Many are med boarded out. Many have, experiences towards the end of their careers that aren't so positive, and maybe they are kind of separated from their team. Maybe they go and do some kind of last year or two of terminal duty somewhere where they're not really part of the unit that they've been with, and so oftentimes there's just kind of some bad feeling that's there. I think there have been some other things in recent years, the manner in which the war has been prosecuted, the rules of engagement, which have changed multiple times over the last several decades, the pullout from Afghanistan, that has been a profound demoralizer for many in the SOF community, in part because they had, so much blood and treasure was spent there, but also in part because they worked so closely with Afghani interpreters and soldiers, most of whom were left behind. And so that has left a very, very, that's had a very demoralizing effect. A lot of folks have been upset by the way the military handled the vaccine mandates, by the way diversity, equity, inclusion has been sort of manifested throughout the Department of Defense. So it's no one thing. It's often a lot of things. And then of course you combine that with all the other stuff we just talked about, the injuries and the impairments, and it's a lot. It's just a lot.
I didn't think about the withdrawal from Afghanistan. I have 3 classmates that were special operators and had the 3 of them on the week after the withdrawal. Mm-hmm. And they expressed a lot of what you just highlighted. And so thanks for flagging that for me. A few moments ago, when you're talking about the different injuries, you mentioned physiological systems probably a dozen times. You've noted that although you're a psychologist, you take a very physiological perspective on helping the people you work with. Would you explain how that's different from, for lack of a better phrase, the average psychologist who cares for similar patients?
Yeah, sure. Well, I start now. I mean, this has been an evolution for me, probably the last 10, maybe 15, 20 years, but we're animals. We are biological animals. And when we injure any part of our body, that can have an effect. We often think of things like, let's just take depression, for example. Depression is a psychological issue. And we have Freudian psychoanalytic theories, we have behavioral theories, we have cognitive theories that explain it. And not to take anything away from those theories, it's not to say that they're wrong, but what we have not really paid attention to is, for example, genetics. We know that depression has a genetic component to it. If your parents had depression, you're more likely to have depression. And now we're starting to identify some of the specific candidate genes that may contribute to that. So that's an example of a physiological thing. Another understanding that I think is really developed in the last, in recent years, is the idea that chronic systemic inflammation in the body is a causative factor of depression. So if we don't eat well, if we don't move our bodies, if we are not living an anti-inflammatory lifestyle, which almost none of us are, we're more prone for depression. And that implies that gives you a clue to one of the interventions, which is to live an anti-inflammatory lifestyle. What does that mean? That means cutting out anything that's going to increase inflammation in the body. What is that? That's sugar, alcohol, processed foods, not getting enough sleep, not getting enough exercise, and many other things. One of the treatments that's been identified as a powerful antidepressant treatment is hot sauna. Taking 3 20-minute hot sauna baths a week in randomized controlled medical trials have been shown to lower inflammation and reduce depression significantly. So there's a whole body of work out there now focusing on more physiological treatments than what therapists typically do. So let's start with that. Traditional mental health care in the West right now is a combination typically of psychiatric medications and psychotherapy. And I'm not criticizing, there's a lot of value in both of those treatments. So I'm not dismissing them at all. Don't hear me say that. I do worry about over medication. That's a very common problem. But we have so many other treatments as well. And I can go through some of those if we have time. Okay for me to just kind of...
Yeah, please do. Yeah. Absolutely.
So one treatment I think so with probably most psychiatric patients today, we should be getting a sleep study and a hormone panel. Both of those measure very important physiological aspects of the human body that will have very negative effects on psychological functioning, cognitive functioning. So I always say we need to do a TBI assessment, we need to do a sleep study, and we need to get a hormone panel, and probably also a metabolic panel. And then follow whatever treatment recommendations come out of that, out of those tests, out of those evaluations. One of my go-to treatments that I recommend for pretty much everybody is a stellate ganglion block. Stellate ganglion block is a physiological intervention. It involves injecting a little medicine into the sympathetic nervous system. And what it does is it lowers the physiological arousal in the body. And it has a lasting effect for months, maybe even a year or more. One injection into the side of the neck. It does not dope you up. It does not impair your cognitive functioning at all. It has almost no side effects or lasting, any kind of long-term risks. The worst thing that can happen typically is it might not work. So about 90% of the people I recommend for this describe it as being profoundly beneficial. What it does is it takes that baseline level of anxiety, which might be at like a 7, 8 most of the time, and it can bring it down to like a 2 or a 3. So for general anxiety, for PTSD anxiety, for people who do a lot of worrying and maybe can't sleep at night because they're ruminating and they're obsessing over things, for people who have what we sometimes refer to as low stress tolerance, in other words, people who are impatient and easily angered. A lot of that is because the anxiety is so high to begin with that when there's a small frustration, that bumps them above the threshold for losing their temper. When we bring it down with this injection, what we see, and it works almost immediately, like literally within a few hours, people describe feeling more relaxed, calm. They're more focused, more present with their family. They can enjoy things differently. Their mind is more clear. They can think better. They can concentrate better because all that anxiety noise is cleared out. They become less angry, less irritable, and they start sleeping better. It helps with the insomnia. And so guess what? You get one of those shots, and for the next 2 to 3 months, at least, most people feel really, really good. And, the medicine will wear off and some of that anxiety may come back. You can repeat this treatment. You can have it done multiple times over the course, you can get it done once or twice a year. But more than that, what it does is it opens a window of opportunity, I think. I've seen this many times. Guys get the stellate ganglion. Sometimes their spouses get it too. I often like to see a couple's intervention with that. And it gives them kind of a holy moly experience. I got a phone call a couple of weeks ago from one of my younger guys who's currently active duty at a tier 1 unit. And he got his first stellate ganglion block, and he called me that night and he says, "You've been telling me about this for months. I finally got it. Holy cow, I feel so different. I've never felt this way before." I mean, he wasn't high. He was just excited about this new feeling of relaxation that he had never felt. He had a rough childhood, as many have. And so he didn't even have relaxation in his childhood. But now it's easier to talk to a therapist. Now it's easier to engage in other lifestyle changes. Now it's easier to re-engage or engage with family members, especially spouses, in a different way. So it really kind of opens the door to, to more healing, more recovery in other ways. So huge fan of stellate ganglion block treatments.
We've been talking a lot about military personnel, and earlier in the show, we briefly touched on first responders, when they experience many of the same emotional and physical traumas. You've written about what you call firefighter syndrome because they also face a high risk of traumatic brain injuries, including impact force injuries and toxic exposures. Can you describe firefighter syndrome and the treatment approaches it requires?
The same. It's the same. The brain injury is a little different, and the toxic exposures are a little different. Firefighters aren't working with demolitions intentionally trying to blow things up, but they do go into structure fires. They do go into environments where it's not known what they're going to be breathing. And sometimes they're in environments that change rapidly while they're in a structure. So that's part of what they have to deal with. Now, there's another piece to this, and I didn't even mention this with soldiers and veterans, but the transition points are a challenge. For soldiers, there's a difficult transition coming home from a deployment or a lengthy training evolution. There's the transition at the end of the career. That's a huge challenge. And we know this. Whether you've been in the military for 2 years, 4 years, 24 years, when you leave the service, you're stepping into a whole different world, and that's a challenge. It's a significant challenge. For first responders, however, let's give them their due here. And this is something that a lot of soldiers have pointed out to me. First responders are putting on the uniform every day or every shift, and they're not fighting overseas. They're not going over to another faraway country for their war. First responders are doing it on the streets of their hometown. It's their neighbors they're protecting. It's their community that they're protecting. It's their own family. So for responders, you have that experience at the end of every shift, taking the uniform off and going home. How do you walk in the door? An hour ago, you were dealing with maybe the death of a child or, the severe injuries in a motor vehicle accident, or, dealing with people who've been horribly victimized by crimes. And then 10 minutes later, half an hour later, you're at home in your living room with your family. How do you manage that? That's quite a powerful thing. And then you have also, you're out in your community. You take your family out to dinner or to a movie or shopping. How do you let down your guard? How are you not looking around to see who's around you, who the bad guys might be? What might you need to do to intervene, to protect people? So it's a whole different psychological challenge for first responders than it is for soldiers. And a lot of soldiers have said to me, what we had to deal with was hard, but not that hard. They tip their hats to what first responders do, on a regular basis at the end, every shift on the streets of America.
Yeah, as part of my research, I found that the younger generation of first responders, kind of 5 to 7 years on the job, they're much more engaged from a mental health perspective in terms of being open to it versus sort of the older regime of 25 years in the force. And I remember a couple of guys saying something would happen, something bad would happen. They'd go to the bar that night, have a beer and a shot, and then walk out, and that was it, and you buried it.
Right.
And so the good news is it's becoming right.
Probably more than one beer and more than one shot.
Probably.
Right.
You co-authored a study about the efficacy of using ketamine infusion in combination with other procedures to treat post-traumatic stress and a traumatic brain injury in special forces. And that caught my eye because, like most people, if they've heard of ketamine at all, we've only heard about it in the context of the death of the Friends actor Matthew Perry. Talk to us about ketamine and its potential benefits and dangers.
Right. Ketamine is a hallucinogenic compound, and it's been long used in medicine for decades as one of several struggling with to find the word here, in anesthesia. So It's often used, it's certainly used in battlefield pain management, but it's also used in like trauma surgery. Usually there'll be 2 or 3 different anesthesias that are used. And ketamine has been one of the, is in combination with others is common. It's also, we discovered that ketamine also is a treatment for depression. And so ketamine is FDA approved as a treatment for depression. It's a legitimate treatment for depression. And a lot of us think that it also treats anxiety and PTSD and some of the existential. It helps people frame the existential, issues and concerns in ways that make it easier to manage. Let me say this, though. There's different ways of delivering ketamine. The only way I ever ask or recommend anybody to use it is to have it infused intravenously into your bloodstream in a clinic under full medical supervision. And so that treatment, and there's many clinics around the country now that will provide this, it's usually 4 to 8 sessions. 6 is a pretty common number of sessions. Each session involves going into the clinic, sitting in a very comfortable chair, receiving the medication, having them run it into your veins for about an hour and a half, maybe less. And then they disconnect, they remove the needle, and you sit there for another hour or so until your head clears, and then you go home. That's one session. What we have found, what we have seen and are really now starting to look at more carefully is ketamine and stellate ganglion block therapy combined into one treatment or done at about the same time there's synergistic effects with the 2 treatments. And so like there's programs, Dr. Lipoff's programs, you can get this through some of the Stella centers and many other clinics around the country. Go in for a week, get a ketamine treatment, maybe 4 of them throughout the week, get the stellate ganglion block treatments done, and that they are symbiotic with each other. They enhance each other. We also are now thinking that both stellate ganglion and ketamine separately, but especially in combination, help stimulate neurodegenerativity, help stimulate the brain to repair and start to heal itself. So these are treatments that work profoundly on many of the things we've just talked about, but including depression, anxiety, existential concerns, and brain health. And there's other things that we think have similar, I don't want to say similar, but also are excellent treatments for these issues. So I think in 5 years, we'll see, not 5 years, I think we're already kind of getting there, but psychedelic medications, ibogaine, 5-MeO DMT, psilocybin, ayahuasca, we're seeing really good effects for operator syndrome, for brain health, for psychological health with these treatments. The research is developing. I think they will be some of these compounds will be more mainstream treatment in the near future. Other treatments, one of the things that I just today got a paper published on the use of transcranial magnetic stimulation. It's a form of neuromodulation. We can individualize it using what's known as magnetic electronic resonance therapy. It's essentially sitting in a chair for 30 or 40 sessions while a magnet pulses a little bit of electrical energy, magnetic stimulation into one side of your brain, and it goes back and forth within the brain. It's not shock therapy. It's a mild stimulation. It doesn't hurt. It doesn't have any dramatic side effects. Most people don't even really notice its benefits in an abrupt way because it's gradual and gentle over the course of multiple sessions. But we're seeing really good benefits from that. Vestibular therapies, speech pathology therapies, hyperbaric oxygen therapy. We're finding so many different things that we have out there. With some of the foundations that I work with, we're now sending guys to functional medicine clinics where they're using things like stem cells and NAD+ infusions to help with brain healing, help with chronic pain in the joints. So there's many treatments that we have out there that we're not widely using with veterans or service members or first responders.
We have just about 2 minutes left would you please take us to the end of our conversation with advice or a story that helps our audience feel more resilient, empowered, and able to succeed in the face of adversity?
Well, that's a hard thing to summarize in 2 minutes, but I'll say this. For everybody who I've been talking about, soldiers, veterans, operators, other combatants or combat support, and first responders, there is hope for healing. We have good treatments. We have the ability to do good diagnostics and good treatments. Right now, it's hard to find those treatments because they're not widely offered by VA or DoD medicine. What a lot of people have found success with is finding the operator syndrome paper, downloading it, going through it with a highlighter in their hand, maybe discussing it with their spouse, and then taking that paper with all the markups on it to their primary care provider. Educate that primary care provider a little bit and present them with sort of a list of things that you need help with. My book has some very specific plans and strategies and even treatment guidance issues in there. The book is really a book I wrote. It's not an academic book. It's for operators, responders, soldiers, and for their spouses. So it's really intended to be kind of a self-help, a very practical guide.
And where can our listeners and viewers find your book?
Amazon. And
keep it simple, right? Dr. Chris Frueh, clinical psychologist and author of the fascinating and insightful book, Operator Syndrome. Thank you for being with us today.
Thank you for having me.
No, absolute honor. And thank you to our audience, which now includes people in over 50 countries, for joining us for another episode of Next Steps Forward. I'm Chris Meek. For more details on upcoming shows and guests, please follow me on Facebook at facebook.com/Chris Meek Public Figure and on X at @ChrisMeek_USA. We'll be back next Tuesday, same time, same place, with another leader from the world of business, health, public policy, politics, sports, or entertainment. Until then, stay safe and keep taking your next steps forward.